I can't tell you how honored I am to have the privilege of presenting the Charles Boucher Memorial Lecture. Charles was an incredibly talented scientist and deep thinker. He had seemingly boundless energy, and I was always amazed at his lack of jet lag no matter what country we were in. And he had a wonderful wit that would leave a group of people roaring with laughter. As a young scientist myself back in 1998, when virology education was founded, I was struck by his dedication to education, collaboration, and the mentoring of young scientists. So while I find this to be a slightly intimidating task, I hope I am up to the challenge. Here are my disclosures. Back in 2018, I gave a talk at the American Society of Clinical Pharmacology and Therapeutics meeting on the pharmacology of HIV cure, and started by asking the question of why we should even go down this path. We have very potent and minimally toxic antiretroviral therapy that is accessible. It's easy to take in a 1 pill once a day regimen, and now an injection once monthly, maybe twice monthly, possibly seeing once weekly therapy or twice a year therapy. These are progressing well. And these treatments suppress HIV replication potently. They restore immune function, and people living with HIV have an expected lifespan similar to those who are not HIV infected. But let's look back at the UNAIDS 2020 goals of 90-90-90. 90% diagnosed, 90% on antiretroviral therapy, and 90% virally suppressed. We did okay on who knew their status, but access to antiretrovirals is still a struggle. And then down the treatment cascade, we see that only 66% of people on treatment were virologically suppressed. So this suggests additional challenges with adherence to medications, which could be due to a myriad of things like stigma, cost, side effects, treatment fatigue. We also know that HIV-infected individuals have a significantly increased risk of conditions with underlying inflammatory causes like cardiovascular diseases and endocrine diseases compared to HIV uninfected individuals. Also, bone fractures and renal disease have also been shown to be increased in people living with HIV. Finally, and importantly, a critical factor in pursuing a cure is that the HIV community is supportive of cure research and is asking for these investigations. So if pharmacology is about getting the right drug to the right place in the right concentration for the right amount of time, then pharmacology is critical in multiple areas in cure research. Catherine Barr from UPenn did a lovely job at CROI earlier this year outlining 4 areas of cure research that are particularly active at present, which include defining mechanisms of persistence, measuring the reservoir, and developing and testing cure strategies. And these are primary areas that we can evaluate in the context of pharmacology also. So let's start with the fact that there is a reservoir. We know that even in individuals who have been treated very early and suppressed consistently on antiretroviral therapy and have a relatively small reservoir, coming off of antiretroviral therapy, they will still experience rebound within 2 or 4 or 6 weeks, as this study showed by Panis et al. And whether we look at replication competent data from the Silicano lab from 2003 with older medications, or the newer Margolis lab data from 2015 with more contemporary medications, it seems that despite many years on antiretrovirals, the reservoir decays very slowly, with half-lives of almost 4 years. So the field has acknowledged that there is no way to treat our way out of HIV with antiretroviral therapy, and that cells harboring replication competent virus will be in the body for decades. Now, most recently, data using the IPDA assay, the intact proviral DNA assay, suggests that the intact reservoir on the left from the SCOPE cohort of about 80 people living with HIV on antiretrovirals decays faster than defective provirus that you can see on the right, suggesting active immune clearance of infected cells, which is a good thing. However, this half-life is calculated to be even longer than the Silicano or Margolis half-lives, on the order of 7 years. And the ACTG 5321 study suggests about 5 years. So this difference might be in longer-lived, deeper reservoirs that were not caught by assays like Cuboa from the Silicano and Margolis labs, and we're going to talk about that a little bit later. So let's look at the reservoir and what mechanisms may be at play here. Now, this is a pictorial from an older paper from Steve Deeks, but the principles still apply. Here's HIV that's infecting either an activated CD4 positive T cell and then becomes a resting memory T cell, or infects a myeloid cell. And then a number of things can happen, particularly with the CD4 T cell. It can stay in this state. It can become activated and undergo apoptosis. It can become activated and start releasing HIV. It can become activated and result in cell-to-cell transmission of HIV. Yet mostly a latently infected cell can undergo antigen-mediated clonal expansion, or here identified as homeostatic proliferation. Additionally, the immune system might be too exhausted or too dysfunctional to clear these infected cells, or they're in a place like B cell follicles where CD8 positive T cells just can't get to them. But from an antiretroviral therapy standpoint, we're most concerned about the release of HIV with infection of new T cells. And so here's where we want drug concentrations to be adequate to protect other cells from becoming infected. Now, there is some controversy around whether this is an important component of the reservoir, since we see little viral evolution in tissues over time, suggesting there's not much antiretroviral pressure, but that's not to say this can't play a role. So compartmentalization of virus or genetic evolution of virus hasn't been necessarily seen in the latent reservoir, but we do have some recent data that suggests that rebound virus is coming from someplace other than lymph nodes or PBMCs and has a distinct profile from viruses in these spaces. So that's intriguing data. From a cure standpoint, we're most concerned about trying to stimulate these persistent cells into making virus and having them cleared by immune mechanisms. So where is this reservoir and where are these cells? Well, HIV RNA and DNA have been found in just about all sites in the human body, even for those on suppressive HIV therapy. And most recent data from the Jake Estes group, as illustrated on the right, suggests that lymphoid tissues, including the gut, lymph node, and spleen, contain over 98% of active and total RNA and DNA in animal models before and during antiretroviral therapy. There are other sequestered places in the body that have their own considerations, like the CNS and male genital tract, which can be drug sanctuaries themselves because it's challenging to get small molecules into them. So the fact that we have multiple places to aim small or large molecules for cure, along with drugs for treatment, sets up pharmacology to play a really big role in the development of cure strategies. Now, we can take two approaches to cure. One is a sterilizing cure, where complete eradication of all replication-competent forms of HIV occur. The reservoir is gone, like Tim Brown, perhaps. And the other one is a functional cure, where the reservoir remains, but there is permanent control of viral replication without antiretroviral therapy. The field currently believes that getting to a sterilizing cure may be more challenging than getting to a functional cure. So the most common approach to cure up to date has been to shock or kick the latent cells into producing HIV. And there are many latency reversing agents, as noted in the figure on the right. Now, the original investigations with first generation HDAC inhibitors, vorinostat, romidepsin, panobinostat, and even disulfiram, did demonstrate safety, but did not really change the viral reservoir. So the field has moved on to next generation latency reversing agents like SMAC mimetics, IL-15 superagonists, TLR7 and 9 agonists, whereby they not only engage the they not only kick, but also engage the immune system in other ways, not just HDAC inhibition. So after the shock or kick, we're looking for a clearing or killing of HIV-infected cells, and then protecting uninfected cells from getting infected and reseeding or even increasing the reservoir. So while this shock and kill approach is most common, there are many others that are in the pipeline, including minimizing the reservoir with early antiretroviral therapy, silencing the reservoir, also called block and lock, and gene therapies with CAR T cells or CRISPR-Cas9 gene editing and other immunotherapies. So to do all this work, there are a lot of systems that we're working with, from cell lines to PBMCs to resting CD4 T cells to humanized mice to macaques. And working in all of these different systems also requires pharmacology to take on an important role. So over the course of cure development, we've seen some significant challenges in the translation of effects in cell lines to primary cells, in the translation of primary cell data to animal models, and the translation of effects between animal models and then application to humans. And since we're dealing with tissues and drug tissue distribution, that may differ between species. And so we're not just trying to optimize plasma concentrations for cure. So it's likely that from one species to another, we need to understand where the lowest concentration of drug may be and to ensure that that place is optimized for exposure. Now, we knew back in 2013, with a comparison of all cellular models using standardly prepared latency reversing agents, that different systems result in different effects. And all of these systems are static. And we see here 5 T cell models, 4 JLAT models, 1 patient cell model, all exposed to 13 stimuli, with no single model capturing patient cell response, which is here. Since most cell lines have either overexpression or underexpression of proteins and enzymes that are unique to them, it may be best to use a model system that's closest to a primary cell in a way that might recapitulate drug kinetics to best mimic what we see in vivo. And so this is where systems like the hollow fiber one might be of benefit, because static systems really don't allow identification of the most important PK parameter for efficacy, whether that's AUC or Cmax or time over a particular concentration or something else. So this type of system can also evaluate drugs in combination in a more flexible way and the optimal staging of drugs. So there's lots of opportunities for pharmacology here. Now let's move from cells to tissue. Another area of opportunity is understanding drug tissue distribution. We know tissue distribution is heterogeneous, and we've known this for at least 2 decades. These are PET images of trovafloxacin in different tissues with low concentrations in blue and high concentrations in red to white. And drugs can have high intra-tissue variability, inter-tissue variability in concentration or exposure, can also have high inter-subject variability. So using plasma concentrations as a surrogate, particularly for cure, can result in significant challenges in interpretation if you don't know about the concentration in those tissues of interest. There are some significant challenges with measuring drug concentrations in tissues, however, and understanding that variability. And you heard from Eli Rosen from UNC at this meeting, who's been working in this area using a technique called IR Maldesi mass spec imaging. So let me show you an example of some of his work showing the distribution of antiretrovirals, efavirenz and tenofovir, in 2 tissues of interest for cure that Jake Estes had identified that we talked a little bit about earlier, colorectal tissues and lymph nodes. So concentrations are going to run from low in black and dark red to high in yellow and white. And here's a cross section of colorectal tissue, the H&E stain, a CD3 stain, and then a section of that tissue showing efavirenz located in the mucosa and lamina propria, and then tenofovir having a more homogeneous distribution. And so the intra-tissue gradient of concentrations here is 10-fold for efavirenz and 3-fold for tenofovir. Now, in contrast, here's a lymph node, again, H&E staining, CD3 staining, efavirenz primarily located to the capsule and a few follicles, with tenofovir seen primarily in the medullary sinuses, and a flipped intratissue concentration gradient of 3-fold for efavirenz and 17-fold for tenofovir. We've used this technique not only to analyze antiretrovirals in tissue, but also cure strategies. And this is an example of panabinostat. Again, an early HDAC inhibitor that had in vitro efficacy in cell systems, but failed to affect the reservoir in humanized mice, in non-human primates, and in HIV-positive patients. And so we evaluated panabinostat distribution in lymph nodes of non-human primates. And on the right are lymph nodes from 3 of these. The top figure is an IR Maldesi image where we see brighter areas in vascular spaces more than the follicles, which may be more where we want to target the effect. So up to 70% of total drug exposure appears to be in the vasculature. And below is a stain for PD-1, so you can see the tissue architecture better and where the follicles reside. So the nice thing about the IR Maldesi approach that Eli has developed is that it's quantitative. And so he measured the concentrations in vasculature and follicles and compared them to cellular studies. Now, these follicular concentrations are still about 2 times higher than the IC90 of cell methods, but based on PD-1 response, which should be really high, screamingly high, is really no different from placebo. And I haven't shown you a placebo picture, so you're just going to have to take my word on that. But it does not appear that this concentration was enough for the activity in these tissues. So an in vitro concentration, either due to protein binding or due to type of exposure or PK parameter needed, may not necessarily translate to in vivo. So this is why we need better understanding of PK-PD correlates. Now, another opportunity for pharmacology is to optimize dosing strategies through pharmacometric modeling. In the Margolis lab at UNC, it was found that daily dosing of vorinostat, again, an early HDAC inhibitor, resulted in tolerance in both acetyl H3 response and in HIV RNA expression. So one of our pharmacometricians developed a simple model of tolerance using data from the clinical studies with a clockwise hysteresis approach and predicted that dosing every 3 to 4 days would maximize efficacy for vorinostat. And this approach was confirmed as effective in a clinical study. However, had this been investigated earlier, either with better mechanism of action information or with animal models, we could have prevented a failed clinical study. And Jose Molto has also recently published a paper in JACC in March demonstrating that the dosing of romidepsin, another HDAC inhibitor that has been used for cure and failed, only hits about 50% of the AUC needed to see an effect of progression-free survival in cancer patients. So if we are using the cancer approach, where most of these HDACs came from, to affect change in HIV cure, then we're not acting in a pharmacologically sound manner when we use small doses and expect to see a response. Now, Courtney Fletcher published a great paper recently in Cure that outlined a number of intrinsic and extrinsic factors that might be related to response to cure therapy. This also prevents significant opportunities to predict dosing strategies for personalized therapeutics. And it extends beyond small molecules and relates to broadly neutralizing antibodies and other approaches to latency reversal. Now, finally, there is a concept of different levels of latency. Perhaps with current therapies, we are just tackling the shallow latency. We are enhancing responses from cells that are already spontaneously coming out of latency, and we're not really hitting deep latency or permanently silent cells. So if we knew what LRA concentration or dose was required to get at various levels of latency and what host factors dictate the proportion of the reservoir that lives within these various states, we'd have a better idea of how to get the right dose to the right patient. So in summary, I expect to see the Nobel Prize given to a pharmacologist who will take our tools and techniques and be the one to lead the field in cure research. For without the insights that pharmacology will provide, I don't believe we're going to get to a cure. Pharmacologic opportunities exist in many areas, including determining which model of latency is most predictive of human efficacy, since the big question is whether we can cure a human, if we can cure a mouse or a monkey. So in cellular models, we need better approaches to understand PK/PD correlations and how to select optimal combinations of drugs and optimal sequencing of drugs. In animals and humans, we need to quantify and predict drug distribution in tissues and identify pharmacologic predictors of latency reversal. And overall, we can exploit pharmacometric techniques to identify critical covariates that will predict efficacy in clinical trials. So with that, I'd like to thank you for your attention. I'd like to thank the organizers once again for such a wonderful honor. And I also acknowledge the people in my lab that make me tap dance to work, our tremendous collaborators within and outside of UNC, and some of our current funding sources. Thank you.